Hi, Regina. Can everyone hear okay so far?
I can hear you.
Seems to be a little bit of feedback. But I'm hoping everybody can hear. Can everyone hear okay so far?
Yeah.
But I'm hoping everybody can hear.
Morning.
Good morning.
I'd rather chip my pride.
What nice little music.
I can't figure out how to, can you all hear me without hearing the YouTube feedback?
I can hear you. I heard a little bit of music a minute ago, but I don't hear it now.
Okay. All right. I think we're good. I had to mute the YouTube site.
I'm jealous, Regina. I almost set up outside too. It's so nice outside.
Yeah, I was just figuring out how to minimize this though, because, oh, here, exit full screen, because I need to make sure I have enough battery. No, I'm gonna have to plug in for sure, but I'll rectify that while we're waiting to get started. Come on, baby. You stay there. I'll let you out and I'll finish my call. She's easier to keep up with. Come up here so I can keep an eye on you.
Come here.
Good morning, everyone.
Good morning.
Morning.
Can everyone hear everyone?
Can you hear
Yes.
This is Dennis. Can y'all hear me? I can hear Courtney.
Hey, Dr. Ashley.
Hey, how you doing, Eric?
Doing well.
Morning.
I believe everybody's here except for Dr. Smith. I've not seen him join just yet, but besides that, Dr. Wallace is here, Dr. Medeiros, Mr. Terwilliger, Mr. Adkins, Mr. Drawdy is present, and Dr. Dunn is also online. I also don't see Dr. Bleacher just yet.
I'll text her.
Can we see? We'll give John a minute here.
Sounds good.
Actually, I'm on.
Oh, okay. All right. Hi, John.
Yep. Good to be back.
Good to be back. I'm trying to get my screen working here. Okay. Intake on. Aaron, did you say the commission members are on now?
Yes, sir. Everybody but Dr. Smith is signed on at this time.
Dr. Smith has?
Everybody but him.
Oh, everybody but Smith.
With the
Okay.
exception, yes.
I can't see the names for some reason here. so.
Okay. All good. We're ready when you are. Just whenever.
All right, we'll go ahead and get started then. Good to see everyone or hear everyone. Wish we could be together in person. But with the COVID resurgence and another wave, it made it a little bit difficult. So I hope by the next meeting in May, as our numbers continue to come down, I assume other numbers are coming down, ours certainly are. I think we're on the backside of the wave. Maybe we can get together in May. But we'll do the best we can on virtual meeting here. Also, I'd like to thank everybody. I know you guys are heavily involved with COVID in some fashion or some form. I know a lot of people have been redeployed from their routine job into various COVID units or other jobs. I know a lot of our nurses are. So for commission members as well as all healthcare providers, I'd like to thank everyone for working so hard and being willing to redeploy and do things that maybe you don't do on a daily basis. So kudos to everyone. Hopefully we're with the vaccine, we're going to be much better off this summer and in the fall. Tying into that, Gina and Liz actually looked at the effect of COVID on our trauma centers. There's been a general thought that maybe trauma was going down with COVID, the volumes, and there might have been some thought of that even at the Capitol. And it turns out that when they looked at the state database and the registry, they found that overall trauma volumes across the state, from the registry's perspective, was up almost 5%. And hold on here. Sorry, realized my video wasn't on. Not that anybody might want to see my smiling face, but anyway, I'll torture you all for a few minutes while I'm on. So when I'm speaking, I'll go with the video and try not to be antisocial. But with that being said, the trauma volumes are up across the state about 5%. If you looked at all the centers, some centers, one center actually reported, and this is all blinded data, so I don't even know who they are. But one center was up 27%, one 25%, 22, 21%, 17%, 10%, 3%. There were a few that actually went down, 2%, 5%. The biggest drop was 18% in one center. But again, overall, when you put that together, the overall volume in this trauma centers was up by almost 5%. That's an important message, I think, for us to know as commission members, as we talk to legislators. There's some thought that maybe that's down. So when we're asked, we want to be able to have some information and say, well, in addition to our hospitals taking care of COVID patients, our trauma volume was solid and up in many cases. And certainly was up statewide. So it was a very big strain on the trauma centers, and certainly any kind of additional funding that we get is greatly appreciated. There's also another thing, a bit of information I think we should know as commission members. There seems to be a rumor, there's no data to substantiate this, but I would call it a rumor, unless other people have data that I haven't seen. I would love to see it. That hospitals are getting rich because of COVID because they're getting funding from the federal government. I don't really know what the financial flow of funds are. I'm sure hospitals are getting some funding from COVID as they code COVID cases. But the problem is that all or many of the hospitals have basically shut down their engine to take care of these COVID patients. And what I mean by that, I'll talk about my facility because it's my facility and I know it pretty well. Our facility had so many COVID patients that we had to shut down elective surgery like many other institutions. And we actually made our recovery room, a significant portion of our recovery room, a non-COVID ICU that was managed by our anesthesia providers. And we couldn't do surgery electively because we didn't have any place to recover the patients, and our surgery staff, our nurses, were actually redeployed to other units. So one hand, yes, maybe you got some dollars from the government for COVID patients, but your main engine, what hospitals really run on, are surgery procedures. That's where they generate most of their income or revenue. And that engine was shut down for many hospitals or greatly curtailed. So I think for us, when we hear those kind of things out at the Capitol, we need to be able to articulate what our real problems are. All hospitals, rural and metropolitan, are hurting with the COVID financially, and we just need to be aware of that. So on a good note, the amended budget was just passed. We received just over $9 million in the amended budget to make us whole. So that's a good thing. And we'll be talking more about that later in today's meeting. As far as the administrators group, I'd like to ask Michelle who has been on that group, has tried to really work hard to get that group off the ground. They've had some preliminary meetings over the last year or two, or year and a half. But now that she's on the commission, I'm going to ask her to chair that. That's the natural transition, and to really reinvigorate and energize that group. It's a little bit different right now because, or difficult right now because most of the administrative types are really involved with COVID, but with our numbers coming down, hopefully over the next few months, people will get a breath of fresh air, and maybe we can pull that together. So I'm going to ask Michelle to really try to push that group forward. We really need input from our administrator group. We have input from our trauma medical directors. We have input from our EMS community. So the administration piece is vital, I think, for the commission to make decisions. And then finally, I'd like to talk about one initiative you'll hear more about, maybe even in Courtney's report, is an initiative in the rural community called March Pause. This is a program that comes from the military, but we're trying to move that into civilian life into rural Georgia. And basically, I may get this a little bit wrong, but March Pause stands for, what's the M?
Massive hemorrhage,
Massive hemorrhage, airway resuscitation, circulation, and hypothermia. And then the pause stands for pain, antibiotics, wounds, and splint. So if we can pulse that out like they have in the military, this is some acronyms they use to make sure care is provided. Courtney is working on this along with Jim Dunn and Liz with an initiative to go into rural Georgia. This is just really getting off the ground, but I think we have an opportunity here to really support our rural hospitals and with a program that seems to already be initiated and working in the military. And I think it'll save lives in our civilian hospitals and get patients into our trauma centers much quicker and in a better shape. So very excited about that. More to come on that, but I think, in my opinion, one of the things that I'm going to be watching over the next year, I think this is one of our most important initiatives, and I commend the folks for working on that. So with that being said, that completes my chairman's report, and I think I need to go ahead and officially call the meeting to order, which I think I forgot to do. And it looks like we have quorum, and I see Erin nodding her head there. So at this time, I'll turn it over to Liz for the administrative report.
Right. And you can stay right there, I think. Can you all hear me okay? Erin?
Yes.
Okay.
I can.
Yes,
I just turned my video on, but I'm not sure if you can you see me?
yes.
Yes. If we could do one thing real quickly, Ms. Atkins, if we could approve the minutes.
Yes, that's what I'm going into. Thank you. Thanks for that reminder.
Yes.
So you all do have the minutes. That's the first document up in your packet. If folks want to take a moment to review, and then I guess Dr. Ashley can entertain a motion.
Yes, can I get a motion to approve the minutes?
So moved.
Jim Atkins, so moved. A second?
Yep.
Who was that?
Jim
Jim
Dunn.
Dunn, second. Any discussion? Okay, all those in favor, and I think just to expedite things, I'll just ask for objections, and Erin will consider that unanimous. That might help you with the documentation. So any objections? I'll give people every time time to make sure they're off mute. Okay, Erin, that passes unanimously.
Thank you, sir.
Liz?
All right, moving on. In your next,
Oh. Somehow the mute button went on her. Hold on.
oh yeah,
Oh, Now, can you hear Liz now?
Yes.
Okay, thank you. Sorry, we're pinch hitting between two machines here. So first up in your packet, you'll see the reappointment letter just as an administrative function of just to provide that in your packet. And then moving on to the super speeder and fireworks excise tax revenue summary. We're providing this to you in graphic format now so that you can look year over year. The goal of this is to look and see where we end up in our full fiscal year allocation. Thank you, Aaron, that's perfect. In our full fiscal year allocation relative to what we get, you know that the super speeder revenues generate quite a bit more than we've been allocated in our budget. And we typically go to the legislators for the mid-year budget to get the true up. So that's kind of what this is reflected here. So if you look at the red line is really the base budget. The blue line is the total revenues for super speeder. And then the green line is sort of the true up piece. So I'll talk in a minute about some legislation that will hopefully guarantee us access to that fund. And that's enabling legislation that ties back to the constitutional amendment that passed in November, that all of the taxes and fees collected as per official Georgia code should be used for those for those intended purposes, so that the legislators can't divert money away from those. And then something that we're keeping an eye on, the next slide, is just the COVID-19 impact, because we know that's impacted our trauma volume. We were watching revenues closely because there was some concern that that could fall. You can go to the next one, Aaron.
Oh, sorry. I was fielding a question.
There we go. COVID-19. So we're calling this the COVID-19 impact because we're looking at calendar year 2019 against 2020, because really the true impact of COVID started hitting around, say, February, March of 2020. So it makes better sense to look at this from a calendar year comparison. So you can see some trends there, though the revenue did really stay on target overall and exceeded the prior year. One theory is just that there were fewer cars on the road, and so more people could speed at that 75, greater than 75, greater than 85 miles per hour rate. So, so the collections stayed pretty consistent there. So, so just keeping an eye on that. I think really though, we look at this year over year anyway, but we just wanted to be sure that our funding wouldn't be impacted as a result. There was so much concern early on in COVID about the financial picture. And then Aaron, if you could go to the next one, which would be the fireworks excise tax revenue and the commission budget allocation. There you go.
There you go.
So I got it on here. Thank you. So what that shows you is just what that excise tax revenue. Now in code, we only get a percentage of that revenue. Katie and I are looking into the story on this because it's not as easy to figure out. The super speeder revenue, we get monthly reports on what those revenues are. We don't find out about fireworks excise tax until this is released in the governor's recommendation for the budget. So we are trying to find out sort of, it doesn't match the percent that we're supposed to get allocated. So we think there may be language in there that speaks to fees or something that are retained by the agency that collects those fees. And I think that's it, unless there's any questions on the revenue piece. All right, we'll move on to the TCAA Virtual Advocacy Institute and Lobby Day. And Aaron, you don't have to page through this whole report because I gave you guys much more information than you would ever want to see. But this was a very well put together program by Trauma Center Association of America. I know that many of the hospitals are hospital members of Trauma Center Association of America, and the Georgia Trauma Commission is a system member of the Trauma Center Association of America. The benefits and the membership privileges are a little bit different for system members, but the Lobby Day was a great way to connect with those federal lawmakers to push forward the Mission Zero, which many of you I know have heard of, the Mission Zero Act, which passed with unanimous bipartisan support. The legislation passed back in 2020, last year, but it didn't get funded. So the push this year is to get that funded. The ask is $11.5 million, and this provides grants to trauma centers to do a military integration in the civilian high volume trauma centers so that military teams can be deployment ready. So in times of conflict, these teams, and it wouldn't just be physicians, this would be critical care nurses, this would be the entire spectrum of teams. So it's a great way to get those teams ready. Also helps out the trauma centers. So the other ask on that was sort of a modernization of the public health money that provides some of that infrastructure support around EMS systems and things of that nature. That is sort of an older legislation that my understanding is has been around a little bit longer. It just needs a little bit of redoing. And I know Dr. Medeiros was participated in that lobby day piece. So I would invite you to comment if you have any other comments about either of those pieces of legislation. I will say that what Dr. Ashley mentioned about the legislators here in Georgia being concerned about the money that hospitals received for COVID relief was a topic from the legislators that we met with over the past 2 days. So this lobby day just occurred yesterday and the day before. And we did get questioned about the hospitals receiving CARES packages and what that we should be prepared with the story of how those funds impacted the centers. We were very clear that that money did not make its way down to trauma patients. That was more about building infrastructure to handle the increased COVID volume and staffing to support the increased COVID volume. So we tried to create a clear story that that was much different. We got to meet with Senator Bill Cassidy from Louisiana, Chuck Fleischman from Tennessee. We met with the legislative aide for Senator Marsha Blackburn in Tennessee. And these were kind of key players because they're in states that border us. So some of our patients are going to them and vice versa. We didn't get to meet with Senator Warnock, but his health legislative assistant, Naomi Plasky, met with us there. And she says that Senator Warnock is well aware of this and that they are in full support of it. And everybody that we spoke to were in full support, whether they approve the money or not. I think it's a different story. And then Jaime Valera, who's the legislative aide for Senator Marco Rubio, we met with them as well. All were willing to sign the letter of support. Senator Rubio is unable to because he's on that appropriations committee. So being on the committee, he's not able to support with a letter, but obviously they support the mission. If no questions on that, I'll move on to the or any comments. I'll move on to the House Bill 511. That's the last piece here. So House Bill 511 is something that I just became aware of actually last week. And this is from Representative Bert Reeves. And this is really what's being called enabling legislation. You have kind of in your packets, you have, and Aaron, you might want to turn to this. This is page 48 on the PDF. You have what kind of just describes in essence what this bill is. And what it does is, again, for that constitutional amendment spoke to ensuring that legislation that already exists that has dedicated taxes and fees, that's perfect, thank you. That those funds actually go to those stated purposes as per the law. And the entity that really got this on the docket was that tire disposal fee that we all pay that's supposed to go for environmental cleanup. And those funds have not been dedicated for that purpose is my understanding. So those folks really got this legislation going. And as you can see, we're included in this too because of the super speeder and fireworks excise tax revenue. So This is working its way through, and I will keep you all posted as to the progress that's made. I have put in, have spoke with folks from the governor's office, as well as the governor's office of planning and budget, about what this will do to our bottom line. This probably will not change our base budget allocation. I was hopeful that maybe this would mean that we would get the entire super speeder revenue portion up front, but it looks like we will still have a base budget allocation, and then we will be trued up in the amended, is what I'm hearing. So as all of these details get fleshed out, I will keep everybody posted on that. And that concludes my report.
Okay, any questions for Liz on the administrative report? Okay, we'll move into the subcommittee report outs. The first one on the list is the bylaws work group, Dr. Michelle Wallace.
Hey, good morning. Can you all hear me?
Yes, I can,
Okay,
Michelle.
great. You never know with Zoom, right? What's going on. So we did meet. We had an opportunity to meet the end of January, and we're still meeting. We need to flesh out our recommendations, but it was a great meeting, lots of great discussion. And anticipate probably by the next meeting we'll be able to give you a final some final recommendations. So just letting you know we are meeting and had some good conversation about it.
Okay, very good. Thank you, Michelle, for doing that. Next up is the EMS subcommittee report. Courtney?
Let me unmute myself so you can hear me. You should have a report in front of you. I think the budget committee's report's there, but you were given a report, and essentially based on the new format, I can run through it right quick, but the project activities that we're working on the AVLS system, which is ongoing. And if anybody's got some of you are very familiar with these things and some of you are not. So if you've got a question about that, please let me know. As an ongoing project that we are within striking distance of having every 911 ambulance in a state with that type of a system. The next one, number 2, I apologize. There is a misprint there, and it's my fault. It's not a license management system that we're working on. It's a learning management system. We've had a couple of meetings, statewide meetings with that. First meeting, we were looking at what would a perfect system do? What would a perfect system offer to the medics and perhaps to the ER staff, our trauma nurses. And the second one, we did a SWOT analysis to try to get a handle on what may be barriers and what may be things that would help us get this done. We have another meeting on March the 4th. And on March the 4th, we hope to be able to come up with the draft RFP using those other 2 documents to try to send out something to selected vendors or any vendor that we think even potentially would be interested in it, and ask them if they could meet our criteria, and if so, how much it would cost. I think from there, once we get that information, then we'll have a smaller group that will review those documents, and then we'll probably end up with a small group of that we will do either virtual or in-place presentations from the vendors to see where we go from that. The EMS training piece, you see ongoing. We work with GIMS on that. They do a lot of classes around the state. I am working with GIMS. I've got a goal that I hope we can get done. What I'd like to be able to show you every meeting is a spreadsheet that says how many classes we do, or they've done, or the subcommittee sponsored, whatever term you want to use, how many's been done, how many hours are involved, direct training for those. And then on the right-hand side, the total number of hours based on that discipline. Let's say if we taught the TEEC class, which is a 16-hour class, and we had 20 students, it would automatically figure those hours and how much for that discipline. And then the bottom right of that spreadsheet would how many actual contact hours we are training people in Georgia on. Number 4 is EMS online training that we are reviewing that. We did 4 pilot projects last calendar year with some mixed results. Right in the middle of that, COVID hit, caused some great problems to that. but we learned a lot of things, and we will be talking about that on the meeting on the 4th also. EMS leadership classes will start not next week, but the week after down at the Jingping Su College of Public Health, Georgia Southern. It's a 4-week project. They have a full class. I think they have 27 involved in that at that point. Number 6 is kind of interesting. 6 and 7 both. One of the things that EMS has some issues with is successful intubations. And obviously, if you do it right, that's a good thing. If you do it wrong, well, no, not so much. So when you intubate somebody, if you put them on a pulse ox, then you can get some information 3 or 4 or 5 minutes down the line about whether you're doing it right or wrong. But the concept of waveform capnography, using it, the first time the patient takes a breath and the tube is not where it's supposed to be, you know it right then. So we worked on that, and we did a survey and actually hit every 911 service in the state of Georgia. There were only a very few services that did not have that capability. We voted to purchase the equipment for those agencies. I think that's being done as we speak. The goal, at least my personal goal, is that I would like one day to see it so that if EMS didn't have waveform capnography and use it, then they should not intubate patients with an ET tube. It is a fairly risky procedure, and to put that on the board, I think they would immediately know. And a lot of services said, well, we couldn't afford it. Well, we've taken that argument out. They can't afford it because we're providing it. We continue to do an equipment grant, so they would be able to buy the disposables using that equipment grant. So we're going to move forward to that, and I'd hope eventually to take that to MSAC with the concept of that eventually being a required piece of equipment for every 911 truck in Georgia. Video laryngoscopy was a little bit different. When we surveyed that, there is a significant number of agencies that don't use that. In the survey, we not only, I'm sorry.
Can you move the display? Okay,
So,
thanks.
yeah, the video laryngoscopy, we are looking at that, but that would be a significant amount of money to do that. Some services who can't afford it don't like it. And it comes down, I think, a lot of times in what you've been trained on. There's quite a few different devices out there that they could use. There's at least a half a dozen. Some of them relatively inexpensive, some of them extraordinarily expensive. So we continue to look at that with perhaps one day we will be doing some of that. Number 8, I'm
Hey, Courtney, sorry, I don't mean to interrupt, but that's a, could I just ask a question there on that number before I forget?
Sure.
Would that be something, well, number one, kudos about the capnography. That's something that really, I think, super important. And I'm super impressed that most of the places in Georgia have that. I mean, that sort of caught me off guard. I wouldn't have thought it had been as high. And then closing the loop with the last few percent, I think is key. So great work on that. As far as the video laryngoscopy, I assume that's the Glide Scope or whatever you want to call it, or whatever brand.
Yeah, GlideScope's one of them, yes.
So would that be something, there is a little bit different skill set with that. It's not hard, just a little bit different feel.
Yeah.
Would that be something we could incorporate into our cadaver lab we're going around the state with? That might be a good place for introduction. Just a thought.
They actually are doing that. They have 2 or 3 different brands. Every time my people go, they want me to buy a new toy. And I'm certainly looking at that, but we do use video laryngoscopy in the cadaver labs. They have the opportunity to do it. And what we have, at least my perception, is that a lot of the medics who train for years and years with a standard laryngoscope, you're absolutely right. It's a different part of your brain, I think, that does it. So I think it's a training thing, but we are using that in the cadaver labs.
Courtney, here's Dr. Dunn here. So just as an overview, I just want to make sure I got this correct. At least in Chatham County, the EMS personnel are not allowed to push drugs in order to intubate. If the patient's at GCS 3, and doesn't require drugs, they can intubate. Is that the standard across the state, or is it variable?
Well, no, that's not entirely correct. They can push they can't use paralytics to intubate, so they can't do a true RSI. I do know some services who are using sedatives to do RSI or to intubate, to sedate the patient so they don't fight, so they intubate. That's not the safest way to do it, but that is the way that the EMS medical directors have set up. It's using a paralytic as part of an RSI is outside the scope of practice in Georgia for a paramedic. Did that answer?
Thank you. That's very helpful.
Okay.
So when you were talking about the waveform capnography, you were mentioning that the EMS subcommittee is going to use the equipment purchase grants for supplying those for those counties that don't have it. Is the price differential on the video laryngoscopy such that we can't do that for that modality as well?
The big issue is the pricing of the video laryngoscopy per unit is comparable. The issue is how many folks even want it versus the number of folks who don't have it. There were very few folks who didn't have waveform capnography, so we had enough money to do that. But I think long term, I would at least entertain the idea that the way that we work towards video laryngoscopy. You know, I've got some medics that work with me who said, well, I don't like to use that. Well, what we have to do is force them in training, force is probably a bad word, but of the opportunity in training for them to get familiar with it. To me, it's a better tool. I mean, with video laryngoscopy, if you use video laryngoscopy and you use waveform capnography, then there should be no issue about tube placement. I mean, with a video laryngoscopy, watch it go through the tubes. With the waveform capnography, every time they breathe, you get confirmation that it's in the right place. So both of those to me, the waveform capnography is a game changer for our profession. Video laryngoscopy can be a huge tool to help us do what we need to do.
Yeah, and the safety issue is, obvious. I can see where this may eventually be the standard of care, where having both is required.
And I think, Dr. Bleacher, I think if you talk to a lot of agencies, they will say that those are both the standard of care today. The problem is there is no real document out there that I'm aware of that says what the standard of care is for EMS. But what we're trying to do is increase the level of competency in the profession. And so.
Thank you.
Any
other questions on those two? Yes, sir.
Yeah, Courtney, this might be an aside. I don't mean to bog down your report here, but it's generating some good discussion. And if I don't comment now, I'll forget. But I think John's point were good too about it. And, when this might be something either now or in the near future, if we bring up some of the research grants again, or whether we don't do that, we just do this independently. But this, with capnography, that's one thing about hooking it up, and it's pretty low tech in the sense for the paramedic to read a screen. I mean, it's really all technology. So getting that in their hands is pretty easy. The video part's a little bit different in the sense, if you just give them a video, that doesn't mean you got to have a lot of training. Well, not a lot. You got to have some training to do it. There's a skill set there, just like with DL. So to write that paper, to write those guidelines, what you just talked about, we need to learn how to do it. It might be a good thing if we did a little research project to where with EMS, we had one or two or three ambulance services that wanted to participate, go through some training, the trauma centers or the paramedics that do it already, whoever wanted to do it, maybe your leadership group, I don't know, just whoever has the skill set and has the time. We could train up some to do it and then see what their learning curve is. Like, how hard is this to learn? What's your, you can be accurate with it, 90% of the time with 3 hours of work or so many numbers, like 5 innovations or 10 or 15, whatever it is. And we could sort of document what the learning curve is for EMS. And then from that pilot study, then we could decide, okay, how do we, if it works, and if everybody liked it, EMS liked it, then we could set a guideline for the rest of the state, how to pulse that out. So, I mean, I think you're on to something here. I would really run with this. I'd be happy to help you in any way. We get Dr. Bolger to help us with this too, you know, but this is cutting edge stuff. I really think you're on to something here. I would consider, you know, looking at this, and maybe this is something you come to the commission for with a grant, you know, to do this. But anyway, just some thoughts.
Okay, thank you. Yeah, and we're very pleased with. I was like you. I was very surprised at the few number of servers who didn't have waveform. Now here's the concern I have. I want to make sure not only that they have it, that they use it. So that's, I think eventually we'll need to be working with the state Office of EMS to start looking at, you know, when somebody intubates, for them to document that they use waveform capnography. It's has saved us a couple of times because we've had some ERs that said, well, you know, the tube wasn't in the right place, and my medics just turned around, turned on the machine, push recall, and printed out and said, you know, when we took our patient off of our equipment, here's the waveform that was there. And so it's a great tool for risk management, but it's also a great tool just to make sure that you're doing what you're supposed to do. I'll go on. Number 8, FY accountability. We've had for quite a few years, been behind the 8 ball about getting our money spent in a timely manner within the FY. And we were on track this year to spend the EMS monies within the FY that it was allocated. So I'm extraordinarily tickled about that. And we've got plans fairly aggressively to make sure we stay in that position. So the data reliability, that's something that that is it's a little bit frustrating to me because I'm part of the problem, not part of the solution. But we want to work with the State Office of EMS to make sure that our services are getting the appropriate valid data to them in a timely manner. I've been working with my vendor a little bit more than I would have liked to try to get the data to them in a timely manner. And as I speak today, I'm still not where I need to be. But we would like to be able to make sure that the directors and the PI people at every service have the wherewithal and training to make sure that they can, one, assess whether their data is being flowed into the GEMSIS system on a timely basis, and 2, if it is being flowed in on a timely basis, is it accurate and valid? So I'm trying to work with that, and I'll tell the world it's not necessarily the most user-friendly system in the world, but I think if I get to where I can, it will be more so. So next meeting is March the 4th. Love to have you all there. We will be in person at Madison, Georgia. Have a place there that we can socially distance. And we will be talking about the amended money that we should adjudicate today. And we'll be talking about the online training and the budget for 2022, I think. Any questions?
Courtney?
Mm-hmm.
Can you send me the information on the March 4th meeting?
Yeah, sure. I'll send it as soon as we end.
Thank you.
All right, Courtney, great report. Thank you. And sorry, I realize now that I jumped over for some reason the budget and subcommittee report. So we'll move into that now. Proposal and budget subcommittee report, Dr. Medeiros. Regina?
Thank you, Dr. Ashley, and good morning, fellow commissioners. I won't feel slighted that you skipped over me, Dr. Ashley. Just a little hurt, but not too bad. Anyway, Erin has up on the screen our subcommittee work group report out for you all to look at. We've been very busy, as you know. We've forced the budget subcommittee members to meet on a monthly basis because we realized very quickly that we were sort of being more reactive than proactive in relation to the state budget. So we have been working on the development of an AFY spend plan, which I'll be going into in just a few minutes. And we are actively working on the FY22 budget for next year. One thing that we are going to ask is that all contractors and grantees submit to us a budget proposal for FY22. That'll be due July 1st. And we are doing this so that the budget subcommittee then could appropriate funds accordingly as they align with our strategic plan and initiative. So it's a more thought through process that we're hoping to get into. We are also working on a reallocation proposal due to COVID, which you've heard throughout most of this meeting so far. It's impacted our ability to have face-to-face meetings and do other activities. So there are funds within our operating budget that we are identifying that we most likely will not be able to expend for the purposes they were allocated for. In this FY, we will need to put a proposal together for the commission to consider for using these funds in a different manner. So Katie is diligently working to identify the run rate of each item on our current budget, how much we'll have to spend between now and June, and then what the leftover funds will be. So be looking for that proposal at the next commission meeting. We are going to establish a contract and grants deliverable work group. We also identified through our work was that there were some inconsistencies between what we expected of one group in comparison to what we expected of other groups. And then also some contractors were able to invoice for funds without any report outs on what they were utilizing the funds for. So we want to put a group together to make sure that we are judiciously allocating funds, expending funds, and then those groups that are receiving the funds are utilizing them for which the intended purposes were for. They don't know this yet, and I apologize for not getting an email out before the meeting, so this may come as a bit of a surprise to you, but I am going to ask Michelle Wallace and Jay Smith if they will work on that work group with me. Jay, if I remember correctly, that was something at one of our previous commission meetings Dr. Ashley had brought up, and you had expressed some interest in that and working on that. So that's why I had asked or proposed that we include you in this working group. And then Michelle Wallace, just because of her extensive administrative background, and she could provide some insights, especially when we look at, you know, what are reasonable expectations for some of these contractors. So I'll be sending out emails about that and getting that work group started so that we hope to get those implemented in probably most likely the FY23 contracts. Not to put you guys on the spot, but Jay and Michelle, if either of you are unable to serve on that work group, just shoot me a message and let me know.
Dr. Medeiros, Dr. Smith is not on the call today.
Okay. All right, thanks. I wasn't sure if he had got on since we got started or not, but all right. Well, good. Then he'll
He's
get an
a
email.
definite yes then, Regina.
Yeah, that's right. You know the rules. If you don't attend a meeting, you get volunteered. In fact, we should make him like the lead of this work group since he wasn't on this call today.
Hey, Regina, it's Michelle. Glad to help, whatever you need.
Perfect. Thank you. Thank you. Moving on to number 4, what the commission also recognized, or through this group, we've recognized that we don't have standardized guidelines for expenses and reimbursements. Again, there's a little bit of an inconsistency between what the expectations were for one group versus another. And we really did need to identify a standard work process for this. Katie and Liz and I had a meeting with the OIG to discuss best practices and sort of get some recommendations. And they recommended we reach out to SAO and DOAS to see there are sort of contract language that's standard, and there's also some reimbursement processes that are standard. So our first step is to reach out, find out what documents they have, and then we'll be drafting our own documents that we'll be utilizing for groups to be able to get reimbursed for certain expenses and so forth. It's just something that's needed to happen. It's probably going to take us a year, if not 2 years, to put all of these policies and procedures in place. So bear with us and be patient. And we'll be bringing drafts and things to the groups and asking for your feedback on these. But I think once we get them in place, it'll help make things go much smoother and much quicker. And everybody up front will understand what's expected. So the final thing that this group's been working on is the development of a budget cycle timeline. And Erin, if you could sort of move to that slide so everybody can see what it looks like. We thought a visual depiction would be helpful for both the commission and all the subcommittee members. This graphic, and thanks to Lori for helping put this together, because this is not my area of expertise. But what we identified were sort of the budget milestones that need to occur throughout a given fiscal year. It aligns exactly with the state budget planning process. And then you can see the second column includes what the expected or key things that the budget subcommittee needs to address and do for actionable items. And then the last column addresses full commission action items and when things will come up for votes and when things will be needed to be approved and so forth. So we're still a little bit behind in this timeline process. We are working very diligently to get ahead of it instead of behind it. And you'll see on there, the first thing that we're asking is what I spoke of earlier, was that all contractors and grantees submit to us a proposed budget for the upcoming fiscal year. And there'll be a email that'll come out explaining that. And what we hope to be able to also develop is a standardized document that everybody will submit their proposed budget on. So that'll be easier for the budget subcommittee then to review and make decisions on. So before I move on to the big ticket item for today, are there any questions on sort of what we've been working on in this budget timeline?
Regina, I love the budget cycle timeline. That is outstanding. I think it gives a lot of clarity to expectations up front. So great job.
Well, it was a labor of love. It was a work in progress, trying to figure it out and trying to get a good handle on sort of what the state's budget process was, and then how do we fit into that and have that. But you all have it. We'll refer to it frequently, and then you'll know when things are expected to come up. So thanks, Michelle. I appreciate that.
Yeah, I agree, Regina. This is really nice. We struggled over the year, trying to be on time and getting hit and being, like you say, reactive instead of proactive and being prepared. So I think this will help us a lot, plus help the folks that are working with us and requesting funds, plus making sure we're tied into state government and give them what they need. I think this will just be a lot more organized. So kudos, good job.
All right. And then the final thing from the budget subcommittee is the budget subcommittee would like to bring forth for approval by the full trauma commission, the AFY proposed spend plan. As Dr. Ashley addressed in his report, we got a little over $9 million in the AFY budget. That's what you'll see at the bottom of the screen here. This proposed spend plan you've seen before. We had floated this out as some ideas. We knew that we were going to be receiving some funds. We didn't know exactly how much in funding we were going to receive. Once we got the final budget, we made some adjustments and tweaks to that. So we would like to bring this forth for approval to move forward on spending these dollars as you see here before you.
So Regina, do we need like the formal vote?
Well, if I understand it, we don't need a first and second, but we do need an acceptance and then open for discussion. I'm learning, Courtney.
You're right, Madam Chair.
Okay. So I guess we will open it up for discussion from the group.
So Regina, just look at this, Michelle, looking at the graphs that Liz put up there. So is this just making us whole with what we had prior years, or is this an increase over prior years? I know the 9 million is, but it looks like our funding dropped, which then just made us whole.
Yeah, so what they usually do is withhold some funds, and I'm learning a government budgeting process, and I guess it's fairly standard where you get a allocation up front. Liz calls it the upfront budget. And then pending revenue throughout the year, they make a consideration as to how much you get in the amended budget. I think on the state level, they call it the big budget and the little budget. Courtney probably knows when he's shaking his head. Yeah, the big budget and the little budget. And so we have not always received appropriated funds. So we have not always received the full allocation of the super speeder money in the past. In 2018 is when we started seeing, I think it was $5 million. But consistently since then, they have been giving us the appropriated dollars, which I take to mean that they've been happy and pleased with what we've been able to show we do with it. So that's what this is. We have the 23 million, we got about 14 because there was a reduction, and then they true it up at the halfway through the year. The challenge is always, okay, how do you come up with something you spend in like 3 months or 2 months? That's always been the challenge. So moving forward, I'm going to really push the budget subcommittee to think through in the early part of the year, if we had all $23 million, how would we spend it? And then how would we divide that out over the months or the quarters so that when we come around with appropriated funds, we're already ready with a plan. And we kind of did that with what you see before you. We started talking about this well in advance of knowing when the AFY budget would come out so that we could put things in place to be successful. So we don't have open POs and money hanging over year over year.
Great, thank you. That's the only question I had.
Okay. All right, then I guess Dr. Ashley, you call for a vote.
Okay, call for a vote. So I guess I'll just take, again, to make it simple, objections. So any objections to the proposal? I'm being slow here because I got to make sure everybody has time to get off mute. Okay, then that passes. Aaron, for the minutes.
Thank you, sir.
Regina, is that it for your report?
Yes, that's it. Yep, I think that's enough, Dr. Ashley. We've been very busy.
Okay, very good. I know, it's a very good work. All right, let's move then into, I understand Dr. Bleacher, I think the Injury Prevention Committee could not meet, and I think you're going to give a report next time. Is that right, John?
That's correct. No report this time.
Okay, thank you, John. So then we'll move into the Trauma Systems Metrics and Data Workgroup Report. Dr. Dunn.
Thank you, Dr. Ashley. As you all remember, the Office of OMT was able to.
Jim, Dennis, sorry, I forgot. I'm going to need to step away for a minute. Can you take over the meeting if I'm not back here in just a minute, please?
Absolutely.
All right, thank you, Jim.
As you may remember, the Office of OMT presented some data back in August of 2020 regarding the time to trauma metrics and some of associated data that we were very pleased to see. From that Trauma Commission meeting, Dr. Ashley appointed a data subcommittee to try to further define those metrics, and hopefully the holy grail obviously is to come up with a time to care metric and to first of all find out what that is and to see how we can improve on that. Sounds like a very simple task initially, but as we got into the details and the weeds, it's very, very complicated. I'll spare you the details, but we did meet on September and discuss that report we saw in August and some of the questions we had for that kind of led to some of our ongoing projects right now. OMSNT is going to be launching soon the Armband project, which will help with the data linkages. Obviously, especially in rural Georgia, a patient may be picked up by an ambulance service, go to a primary hospital, and then transported by another ambulance to a definitive care hospital. And so there's at least 3 or 4 data linkages that have to occur on that same patient, but that patient gets a new trauma name and a new medical record number and another data number at each of those stops. So hopefully with this Armband project, we'll be able to link all those records together and then hopefully be able to better define the time to care metric that we're so anxious to try to get to. In the investigation process, we sent out a survey to all the trauma registrars in the hospitals, or at least some of the hospitals, and tried to find out where they were getting their EMS data from, because 2 out of the 3 data linkages rely on EMS transport. And so we found that most of the facilities are using Hospital Hub, but Hospital Hub is not perfect, just like anything else is not perfect. So we're working on trying to fill in those missing data linkages so that we can get better data to help us with the time to care metric. In addition to that, we initially were going to bite off the whole elephant. As you can see here, several facilities almost daily are using Hospital Hub to try to get their EMS data, but there are issues with that. They're having finding trouble finding the data. The system is incredibly slow. There's missing data. And then some facilities are tapping in directly to the individual EMS computer systems to get their EMS trip reports. But I think Hospital Hub is probably going to be our answer because it's a one-stop shop. We just have some cleaning up to do from a Hospital Hub standpoint, and we're working on trying to find out what those issues are and how we can help from a commission assist with that cleanup effort. Can we go back to the initial report slide, please? Thank you. And then we were going to try to do the whole time to care metric, and then we thought it would be best to start with a small subset of patients. And so we wanted to go to the high value patients. So we're going to be looking at the shock cohort of the sickest of the sick, if you will, because the time to care metric on those individuals obviously are time sensitive versus someone maybe just with a broken ankle. So I think this is an exciting time for us because we now have a dedicated group looking at this and trying to move the football down the field. We are going to meet again in March. I think March 25th is our next meeting. And so there's a lot of work to be had, a lot of work to do, but I think I'm excited because I can see this coming to fruition, sooner rather than later. So I'll be happy to entertain any questions at this point, but I think I'll leave it at that. If anybody has any questions on the devil in the details aspect of this, I'd be happy to address it at this time.
Jim, do you break out PEDS for the time to definitive care?
Well, ideally, we'd be able to, look at all subgroups, geriatrics, peds, and everybody. But I think at this point, we're just going to look at the adult shock cohort because we need enough people in there to make it worthwhile. But we don't want to be overwhelmed with trying to gather too much data. So I think we're going to do adults first, and then eventually move into peds and then geriatrics.
Thanks.
Liz, did I misstep anywhere along the line? I didn't say anything that was totally inaccurate, did I?
You captured it wonderfully. Thank you very much.
All right. Well, if there's no more questions on the metrics data subgroup, we'll go right into the rural trauma care work group, and I think Courtney is involved in that as well.
So you got our report in front of you. The training and education piece, at least in rural Georgia, we perceive that there's a huge need for this. 1 and 2 were kind of intertwined, the March Pause initiative. We had looked at this some time back, and were calling it 5 things to save a life. And Dr. Ashley had been very involved in that. And simultaneously, pretty much Liz and I both stumbled over March Pause, which did 2 things. One, it gave us some validation that the things that we were thinking about, there was some paperwork behind it, some research behind it. So that gave us a good bit of a forward momentum. I have been looking for and frustrated with when my medics pick up someone with a STEMI, they know exactly what to do because there's a set algorithm for that. If we pick up someone with a suspected stroke, same thing, a suspected algorithm. There's an algorithm for that, and we know exactly what to do. Trauma becomes more problematic. It's a little bit more difficult, I think, particularly with blunt force trauma, to identify the criticality of it. But looking at the March Pause, we think that we can utilize that to develop that algorithm so that the medics across the state will be able to utilize that, and the ER centers in rural areas will be able to utilize that. The CDC's got a good scheme on when to go to a trauma center, but it doesn't tell you what to do until then. It just says take them to a trauma center. So the March Pause concept is to tell them what to do while they're getting ready or while they're sending them to a center or en route to a center. So the training and education will be surrounding that. We actually met earlier this week with Liz and Nita Ham, and I had a conference. And Nita is working on some stuff. She is with the Office of Rural Health. She's got a great history in EMS and pre-hospital, but we talked about how we could collaborate on these initiatives. She's going to be doing a survey to the rural hospitals, and she's invited us to put some questions in there to help us understand what they do know or don't know about trauma education. So we're trying to get that information so that we can devise a plan to meet those needs. I did put in on this thing, you can go to that hyperlink there if you want some more information about March Pause. That's the military document. They've got a lot of research in it. I have been talking with a lady named Carol Crockett. Carol is out of Savannah, has been teaching the military side of this. She teaches the special ops. She was gone one time. I couldn't get in touch with her and ask her where she was. And she said, I could tell you, but if I did, somebody literally would come kill you. I said, I would not want to know that. Thank you very much. So she teaches these people who live and breathe this type of work. So I have asked, and she offered, and she's going to send me some information. When I get it, I'll send it out to the group on what we can do. Data collection, we continue to look at methodology of getting information from the rural hospitals into the trauma registry, because you don't know what you don't know. We don't know what they're doing. This concept that we're considering would perhaps hire somebody on a contract basis to go online, perhaps, or go to the center. I think with modern data systems, I think we could probably do it online, and we would be able to essentially sit down and look at what their data is. So we would know how many trauma victims they have, how long they're in their ER, how long they take to get them out of their ER. One of the things we're interested in trying to figure out is how long they're in the ER because they're in the ER, or is the delay because of the ER? Is the delay because the trauma center hadn't accepted, or is the delay because EMS is not available? So we're trying to figure out all those things so that we can make a plan for improvement. Evaluation and sustainability of rural centers, that's something Liz is working. They have a work group now for level 3s and 4 centers. We've lost a couple of centers in the last few months. I think we lost a 3 and a 4. Renee may touch on that in her report, but it's becoming financially very difficult for them to do. And what I see in the rural centers, if they don't have a champion, a true champion that is willing to take it on and make it happen, because so many folks in rural centers wear so many different hats that if it's not an absolute requirement, they don't do it. And so the data collection piece that we're looking at might help with that, so that takes the workload off that individual who has 6 other responsibilities. That might help with that. But the goal is to be able to sustain those centers. The time to care metric is something that Dr. Dunn mentioned with the data group too. And that is essentially, we're trying to determine if somebody gets critically injured, or not necessarily critically, but how long does it take them to get from the scene of the accident to the place they need to be. And that involves a lot of working pieces. It involves perhaps the first ambulance service, the first ER, a second ambulance service, or a helicopter service, and the end result, the trauma center. And it involves being able to put those all of those data pieces together so that we can get that knowledge, because it's critically important. You know, I'm a rural hospital. It's a level 1 center, but I also do EMS. And I recognize the stretch that a lot of EMS agencies have in being able to take STEMI patients to a cath lab, and a stroke patient to a stroke center, a pediatric patient to a PEDS ready center. And so it becomes very difficult in rural Georgia with small numbers of trucks and long distances to travel. So we're trying to get a handle on that. And I'd answer any questions, or try to anyway. Thank you.
All right, thank you, Courtney. And then I think we'll wrap up the subcommittee reports with Liz, if you want to talk about the level 3, level 4 work groups.
Thanks, Dr. Dunn. This level 3, level 4 work group, if you may recall, probably a year ago when we approved the performance-based pay metrics for FY21 to make a more relevant group for the level 3s and 4s to share their concerns. We created this group as part of the pay for performance meeting so that they were attending something that addressed their needs specifically. So unfortunately, due to COVID, the first couple meetings were canceled, but we made it a priority to put it on the calendar for last month, and we did meet, and there were 11 of the 14 level 3s, level 4s present. And we basically just did kind of an open discussion on what were some of the challenges and concerns that they all share. And overwhelmingly, it's just the ED volumes and acuity, not necessarily just related to COVID, because as Dr. Ashley mentioned in his report initially, a lot of those really high increases in volumes that we saw during COVID from over last year were in some of the level 3 centers. So while they may not have equated to huge volumes in terms of, 27% when your volume is under 1,000 isn't that many patients, but for that hospital that's trying to manage that, it is a huge burden on them. And then one of the other things that they mentioned was, and this wasn't necessarily specific to just trauma, but when they had a patient that needed to go or get referred to tertiary care, that they were having very little success in being able to get timely interfacility transfers. And that just has to do with the burden on EMS systems and trying to get folks. Courtney, I know this is something that you're very familiar with. It's really hard when you only have 1 or 2 trucks covering the county, and then you have to take one of those trucks out of service to try to get a patient to where they need to go. So I think that somehow, Courtney and I will work in the background to kind of integrate this group in with that role group so that we have one group that's kind of addressing all the challenges. But I do think this was a great conduit for that group to get together and kind of network, and also to get them engaged in what we are trying to do in South Georgia, because many of these centers are down in that South Georgia. If you kind of cut the state in half, a lot of them are down there. And as Courtney mentioned, yes, we are losing 2 facilities that are in that South Georgia area. So very concerned, again, over access in the South Georgia area. So we did go ahead and schedule another meeting for May. And as we said in the beginning, hopefully we can get back to some face-to-face meetings. And this group would love to get together in person to kind of talk about what things they can be done and what recommendations that group can make, if any, to try to get into our strategic plan and funding priorities. They would like to have more representation and more voice for the level 3, level 4 centers. So I think that's incumbent on us to kind of work out what that looks like. And unless there's any questions, that's really all that I had for that.
All right, thanks, Liz. Any other questions for Liz regarding her committee report? If not, then let's go ahead and, in an effort to stay on time, move right into the GCTE subcommittee report. Jesse?
Hey, and Dr. Dunn, thank you. I was just now able to get on the call due to some technical difficulties. I was going to see if Karen Hill was on. If so, she was going to give the report. If not, I will go forward and do so. Karen, are you on? All right, so, okay, I'll go ahead and do it, and I'll be very brief for the sake of time. I know you guys have our report in your packet. So we actually moved our next GCTE meeting until tomorrow so that we could follow the commission meeting in order to give reports back to that group from this meeting today. But I will talk about the individual subcommittee reports. So the trauma registry, I think we mentioned at the last meeting, but they did complete the Georgia Data Dictionary. It's been completed and finalized. after lots of work by Tracy Johns and her team on that. They have their subcommittee meeting date set for the rest of the year, and Tracy is working very hard to be able to provide continuing education credits for the registrars for those different meetings. She's also looking into how much more funding she might need in order to provide that continuing education. For the Performance Improvement Subcommittee, we did have a change in leadership with that group. Anastasia Hardigan had recently left her position, and John Pope of Cartersville Medical Center has taken over that role, and Anastasia's working with him through the transition and still just working on projects like the PI playbook that they're working on as a resource, and then also looking into adding some important info about the PRQ for level 1 and 2 centers, as well as level 3 and level 4 centers. So they are continuing to work on that as their main objective. The pediatric group, they have resumed their meetings after the holidays. They met in late January. They are still working on collecting data from the pediatric radiology project. And let's see, they have a couple of project ideas in the works. They're looking at some good standard of care with functionality at discharge and with Pew score. Also looking at pediatric gunshot wounds, focusing on aftercare and follow-up, and they're reviewing the existing programs that are there to, kind of build upon for that, as well as they wanted to draw attention to April is Child Abuse Prevention Month. Then moving on to the Injury Prevention Subcommittee, that group has continued to meet. They very well attended. Their work still continues to focus around fall prevention strategies, intentional injury strategies, and then they are developing a new special events task force to work on educational offerings around the Cardiff program. And then our education committee is still working hard to get some courses out across the state, especially to the rural areas. We're able to provide a topic course to the rural centers in April, and then also they're offering an optimal class on April 30th. I think applications for all those are closed at this point. And then last, I just wanted to say, and I don't know if Karen has made it onto the call yet, but as you all know, Karen Hill has served as the chair for GCTE for almost 2 years. She's actually transitioned out of her role of trauma program manager at Eggleston and into the manager of critical care transport for CHOA. And so we appreciate everything that Karen did in this role, especially during this rough past year. And she'll be missed, but she'll stay on as a past member. And my term as chair will start actually effective after our meeting tomorrow, and we will be taking a vote for our co-chair. So that is all I have, unless anyone has any questions.
Thank you very much, Jess. Appreciate it. Move on now to Lori with the Georgia Trauma Foundation.
Hey, good afternoon. Good to see everyone's face, at least virtually. Just a quick update there, Jesse. There are 3 courses that are still open to apply for scholarship through the end of this week. The virtual rural topic course that she just spoke about, also the optimal course, and the trauma medical director's course. So those 3 courses are still available to apply through the end of this week, and then all of that will close. So if you have anybody within your network that may be interested in those, there are seats available still in all 3 of those courses. And then just a quick update on the Trauma Foundation. We, under Dr. Bleacher's leadership, he has been a saint to come in and really drive us in a new direction, which is great. And so we have been focused on really working in-house to make sure our priorities are in order. And one of those priorities was to hire a director of philanthropy, which we have done, Cheryl Ward. She is viewing on YouTube. And so hopefully you guys will meet her, or you will meet her in the future. You will actually hear a lot from her. But I'm very excited to have now a staff of 2 at the foundation. And we have a lot of things in the works, and we are working on our strategic fundraising plan. So lots to come there in the near future. We, in the November meeting, you guys approved the addition of Dr. Nympha Saunders, from recently retired from Navicent, and Macon as the CEO. And she hit the ground running and has been a huge asset to us just in her first couple of months, and is really helping us develop some new framework for that fundraising strategic planning. So we are trying to really nail down our plan before bringing on any additional board members, but that should be in the next month or two, and then we will continue our recruitment of 1 to 3 board members over the next year. And we're trying not to fill the board completely all in 1 year, only because we want to have staggered terms, much like the commission, so that everybody's not rolling on and off at the same time. We have initiated, and just so that you guys know, in the report, I guess I just went running, but in the report now, since Liz has taken the position of the executive director, we now have specific deliverables. So I'm providing those deliverable updates in your package reports. But we have now moved to having board meetings bi-monthly, and we have executive committee meetings on those off months. So we're really meeting monthly to stay on top of our future direction. And yeah, as I said, we're working on our strategic fundraising plan. Nothing has been announced yet, but there will be some coming soon. Unfortunately, we should all be doing Advocacy Day at the Capitol, or should have just done it here recently, but that was not an option. But as Liz talked about them participating in TCA's National Lobby Day this past week, she took some notes, and we do think there are some opportunities to do some advocacy stuff virtually before the end of the session. So we are going to discuss that and see what kind of opportunities there may be. Maybe just some focus groups with some legislators around hot topics, or provide a video, but something to let them know that trauma has not slowed down, as Dr. Ashley talked about in the beginning. I think it's important for them to know that. And then as in reference to our biannual meetings, our trauma symposium obviously didn't happen this spring, but we are in hopes, in planning to bring that back in 2022. We are looking at the first week of March in 2022, but as soon as those dates are confirmed, we will let you guys know. But we are planning to move forward with Day of Trauma in St. Simons. Kathy Browning at Georgia Society for ACS is still planning to have their annual meeting. And we know that some people, even though may be vaccinated, still may not be able to travel. We are looking at a hybrid version for that. Gina and I have been talking at length about what that meeting could look like. So plan for those dates, August 13th to be in person in St. Simons, but obviously know that there will be a virtual option as well. So I think that is it for me, unless Dr. Bleacher, you have anything to add?
No, that pretty much covers it, Lori. Thank you.
And is there any questions for us?
Hey, Lori, with the Day of Trauma, is there a differential in registration fees if you're in person versus virtual?
That's a good question. I don't have an answer for that yet. We are going to survey to see what it looks like from the trauma community as being in person, because right now, as you all know, we are really the majority in that meeting, and we fill up the hotel. And so right now, Kathy Browning has a lot of rooms available, but we really need to get a gauge of how many people are going to be even interested in traveling, and then that will really determine the cost and the fees. So we will be aggressive in reaching out over the next week and trying to determine what that actually looks like.
Lori, this may be too early to tell, but I imagine we're going to have social distancing requirements there. So is there going to be a max number that we can even take at that meeting?
Right now, we are expecting a lower number. We don't expect to fill the space, but yeah, there will be social distancing. She does have the big ballrooms reserved. So our thought, we know that it's going to look different. It may not be everyone meeting at the same time. And really just trying to figure out what that meeting is going to look like. So we just got confirmation from Kathy that they were moving forward the week before last. So we've kind of just been scrambling to say, okay, we've made the decision. We're going to move forward, at least with trying to offer a hybrid course or a hybrid meeting. And so I will definitely have more details and keep you guys posted even before the next commission meeting, obviously, and as it becomes available.
Thank you, Lori. Any other comments or questions for Lori regarding her report? If not, we'll go with Gina for the GQIP update.
Thank you, Dr. Dunn. We have really got some exciting things going on. The 1st of December, we kind of rebooted the whole group. GQIP paused like everything else due to COVID. So we had a reboot, reintroduction of everybody. We've had a good bit of turnover in staff. So we do have a lot of new members, which is really exciting. We have some different folks involved in some of the groups. So we actually have completed our first exercise. We did a TQIT report performance matrix summary exercise. We had 100% participation from all of the centers, including the level 3s this time and the PEDS, which is something new. So it was really good to see the summary of those reports. We've also started an opioid and AKI work groups. Both of those have already had a meeting, begin to discuss some of the projects that they may want to look at and work on. From that standpoint. And, opioids really plays into some of the state's efforts to address the opioid epidemic. So I'm really excited to see what comes out of that group. And AKI just seems to be an area of opportunity we continue to struggle with from that. So after reviewing the performance matrix, we also saw we've got an opportunity with our severe TBI population. So we are pulling together a work group for that as well, and they will have their first meeting next week. And we already have had some leaders for that group step up, so that's great. And then we are going to work with the registrars about doing some data validation to kind of go along with that TBI work group. We're going to do some validation around the GCS motor score. We introduced that project at the registry subcommittee meeting this month and hope to get it out to the trauma program managers and registrars to get that completed over the month of March with that. So a lot of good things going on with the GQIP group, and I'm excited to be a part of it.
Can I just add a few things? This is Chris Dente. Thanks for that report. And we're all very excited to have you. I think our ability to build on what was GQIP 1.0 into GQIP 2.0 will be hugely impacted by your experience and your energy. So, really happy to have you. The work groups are an exciting sort of new step. It'll allow us to get more people involved in what we're trying to do. We have a lot of expertise in the state in multimodal pain management, and there's a lot of interest in understanding a little bit around our opioid usage in specific trauma populations. It's also an opportunity to collaborate with the NSQIP side of the GQIP collaborative, because they have some data already around opioid usage in certain surgical populations. So there's certainly opportunities there to understand how to build some education and, an opioid reduction strategy that would be something that would be useful both in trauma centers and in our NSQIP centers across the state. AKI is a significant problem across our trauma centers. If you look at our TQIP reports over the last 3 or 4 years, and we tried to get some stuff up and running, I know, and we, again, have a fair bit of expertise in this state, and people have spent some time drilling down, you know, Dennis's group at Navicin especially. And so there are certainly opportunities there. Again, there's opportunities to collaborate with GQIP because they also have problems with, with NSQIP, because they also have problems with their acute renal failure population. And there's, you know, some overlap, obviously, in terms of what those patients look like. Right before COVID, we actually collected a wide swath of data around acute kidney injury from 2016 and 2017, and even did a matched cohort. And the analysis got paused, but we now have somebody that can do that analysis for us. And that'll increase our understanding of where our opportunities are for acute kidney injury. And then, as Gina mentioned, we have a traumatic brain injury work group that's going to get up and running. And any of us who take care of our traumatic brain injury patients know we certainly have opportunities to improve our care in that patient cohort. The other exciting news, and I'll close with this, is that I think Gina, I, Liz, we're all very excited when the Arbormetrics funding sounds like it is now approved. Our ability to do our own complex statistical analysis will allow us to push forward with many of these projects in a more timely fashion. Right now, we're still centered on what TQIP gives us back, which, while, you know, is something we can work with, has its inherent limitations. So having our own data management platform, our own support, you know, statistically, will allow us to, I think, do a lot more, just like the Michigan Collaborative does. And it will make our collaborative that more unique, and that and the information we get from it that much more timely. So those are our updates. I think we should have a pretty good year, and you know, we'll be part of the planning for the Day of Trauma meeting as well. My hope is that the work groups will have some work products to report out on at that meeting.
Thanks, Chris. Any comments from the group or questions for Dr. Dente or Gina? I just want to echo Chris's comments, Dr. Dente's comments regarding the addition of Gina Solomon. I am super, super excited about your presence here, Gina, and I look forward to continuing to work with you again. So I'm really glad that you're part of this.
Oh, I appreciate it, and I'm excited as well.
Hey, Dr. Dunn, and for Gina and Dr. Dente, could we, given that the commission just approved that amended budget, perhaps one of the things that we could be prepared at the May meeting is to develop a timeline of implementation, and then sort of a, you know, a established evaluation point, since when we fund things now, we want to try to have, you know, sort of shelf lives attached to everything, and reevaluation to see if it's something that we continue on. It was built in as sort of a 3-year project, so that just in case our funding got rated, we wouldn't, you know, lose all the money in setup. So maybe that could be part of the report next time, if you guys think we could work that out.
Yeah,
Absolutely.
for sure.
All right, if there's no more discussion, we'll move into the final report of the day from David or Renee regarding OEMS&T.
Yeah, Dr. Dunn, it's David. I'm going to let Renee go first.
Hello, everyone. Well, you have the report in front of you, but just there's a couple of updates since this was originally sent out. We did confirm the level 3 that we had redesignated, that has been approved. And as you know, we still have issues as far as continuing with site visits because of the COVID. Most of these facilities are smaller hospitals. And again, as several people have mentioned, they're tasked in other directions during this. One of the most significant things that have happened since since I sent this report to Liz in January, is we have lost 2 facilities. One is Taylor Regional, which is in Hawkinsville, Georgia. They were actually a level 3. We went down to a level 4 to try to ease some of their burden, and they have determined they still cannot fulfill that process. The other is Appling Healthcare, which is in Baxley, Georgia. They were a level 4. And it is very disconcerting to see these small rural facilities drop out, because we did work very hard with them, offer solutions to what their weaknesses were. Liz and I actually went on a visit together to Appling to talk to their facility and see what we could do to support that facility in remaining in the system. And it just could not meet the criteria. And so, they always have the opportunity to come back. I submitted the 2 letters signed by Dr. Toomey yesterday to Liz for your record, so that you would see those facilities are now have been de-designated. And there is a new list coming out of the updated trauma centers. The good news is we do have several facilities in Region 4 that will be coming online, primarily level 4 centers, but as you know, we do not have coverage in that area right now from any trauma center. So as soon as things lift to maybe take a site team in, and I'm actually hopeful we might be able to do that within the next 30 to 60 days, that we can get them taken care of. I think that would be a great asset to have someone in that community. And then, of course, we have several others that are sort of holding in the links here about their designation, and COVID has definitely impaired some of those. As you know, Phoebe will be a new facility coming on, and they're still diligently working on that in the midst of the COVID crisis. I'm set to go down there probably within the next month or so to just do a tabletop, just a discussion with them about where they're at in the program and sort of what their timeline has now been adjusted to. So we're still working very hard with the centers and hope that we can keep this short up. I am participating in the rural work groups for the hospitals with Liz and Courtney and those things that are going on with the commission. So I think if we can focus on some of these things, hopefully we can shore up the ones we have and assist them in staying in, but also recruit some new members. And the data collection that Courtney mentioned, we do have a new software program that would be available to these facilities at no charge. So that's our little caveat for them. We're in the second quarter of our new license management system, and we're still, working through the processes. I know it's very tedious, but I think overall, once we get this whole program implemented and we get the quarterly reports in the system, I think that we'll be able to move forward. We did send out a survey to our trauma program managers this past week. It's due this weekend, about the issues that they may be having with the system and where we can assist them to make it better. Also, what is appropriate in the report. Part of our report is what we report to the commission, but we want to make sure that everything we put in those reports is usable information and helps make the task of some of the centers a little bit better. But that's sort of the new processes that we're going through. Like I said, on this particular thing, we had 3 centers that we had sent the non-compliance letters. Of course, 2 have dropped out. The third one did choose to step up, and we've been assisting them diligently in getting their reports and data caught up. So I think they're going to be back on track. That was another level 4. So we're moving forward with that. We do have now 4 of our trauma centers confirmed with ACS virtual visits. 2 of those facilities were, this is their initial verification visit. Well, actually 3 of those, it was their verification visits that were canceled due to COVID. So we have 3 set up for virtual visits, and then 1 was a re-verification visit that has been scheduled. So the first one will be next month with the ACS. So I'm very anxious to participate in that and see how the virtual visits run. It's something we're going to have to adjust to, I guess, for the future, regardless of how the COVID situation comes out, because I think they're finding out these are very helpful in getting some of the centers caught up and on schedule again. So unless you have any questions for me, I'll defer to David.
Thanks, Renee. So the primary thing I wanted to talk about, we've come to the commission before talking about the learning management system that we wanted to get. We have secured funding from this. It's not trauma dollars. It is from a different funding stream that the Department of Public Health has secured this. And so this learning management system will be what we use for all of our mandatory trainings that we do, other than like CPR and ACLS. So we will have trainings on there, but we also want to use it for, if there's a new trauma medical director or a new trauma, program manager or something at a site, that we want to be able to have trainings on this system for them. This system is very robust. It allows for every EMS agency in this state will be able to have access to this, where they can put on their own courses. So they still have to get courses approved through us, through our usual process. But if they want to put online courses on there, they're going to be able to. Again, and it's again, we're assuming the cost for that for DPH is. But it's, as we've done trainings across the state for data, for example. So a couple of years ago, Kelly and I did basically a tour of the state, and we went around to all the different regions and we did trainings on the GEMSIS EMS data system. And what we found is that while they were well attended, you can't reach every medic in this state by doing travel, because there's 24,000 licensees in the state, and it's kind of hard to reach them, with that. That's just very, very cost and time prohibitive. And so this is one of the benefits of this system, is we're going to be able to put training on here that can reach every medic in the state of Georgia. So again, it's already been purchased. We've already done our training. We've actually already been working with other state agencies that are going to be putting some training on this as well. So for example, we've worked with the Department of Human Services Division of Aging, and they're going to be able to put some courses on there about elder abuse, neglect, and exploitation. That's something that's obviously a very big concern in our state. And so, the system, again, is going to be very, very robust and allow us to have this. And so we're really excited about that, and about, being able to put training for our trauma centers, our stroke centers, our cardiac centers, and all of our EMS agencies. And I think that's the bulk of our report. If there's any questions, we'll take any questions.
David, is the learning management system a website? Is it a video conferencing tool? What exactly is it?
So it's a system where we can put interactive courses, right? So it's a true learning management system. So we can put interactive courses. If an EMS agency decides to put, let's say they want to put a protocol exam, right? So they want to put their protocols up there, and they can put a protocol exam. This system can do that, and it's free, right? It's free to the agency to do that. And you can put quizzes, you can put evaluations, you can schedule conferences with this system. You can again put the online education that's self-directed, interactive education. So it's not like a WebEx, right? It's an actual learning management system, and we'll give more on that. They're finishing our customizations for the state of Georgia to add some fields on there, but like I said, it's going to be a great tool for everyone in the state to do.
David, when that's up and running, I think it would be beneficial for the commission to get a dry run, or just a demonstration on what exactly that system is all about, and because I think that would be very helpful for us.
Okay.
Any other questions for either David or Renee? All right, thank you to both of you. Liz, did Dr. Ashley have any new business that we needed to discuss?
We don't have any new business, so to speak. We do just have a couple of announcements. One, just to tag on to the end of David and Renee's report, is that they are still submitting that time to definitive care data that we requested. I don't include it in the report because now that we re-engaged the data subcommittee, you're really dealing with that data, Dr. Dunn. So I'm not putting it in the packets unless we're still kind of distilling down what the important information is from that. So if you're okay with that. And then the only other thing is that I just wanted to, Dr. Dente has one update to share, and I wanted to just advise based on the budget cycle timeline that Dr. Medeiros presented, we will have to have a called meeting by the full commission in March just to approve the FY 22 budget. So, I'm sorry. Yes, we just approved AFY 21. We're going to have to approve once that budget makes its way through the legislators and gets the governor's final approval. We will have to approve that, and that again goes back to that base budget. So we'll have to have a called meeting just to do that. The reason to do that is that, and you don't have to go back to that screen, Aaron. The reason to do that is just because that enables Katie to go ahead and start working on the contracts so that we can get contracts out prior to the start of the fiscal year. So the called meeting will be for the sole purpose of just approving the FY22 budget, and then our regularly scheduled meeting set to go as an in-person meeting at GIPSTIC will be on May 20th. And then I think Dr. Dente wanted to add one other item.
Yeah, I'll just be real brief. The the one you see all these great reports here. The one thing we've never really been able to find too much traction for is our state COT. So in discussions with several leaders from several different organizations, I would like the COT, as I'm finishing up my second chairmanship, to have a value add to our system. And our state system has really expanded. A lot of great activities, as you can tell from this last couple hours. But I think there's some overlap and there's some room to improve our efficiency. So I reached out as the state chair to the leadership of a lot of our organizations, and we're going to arrange to just sort of have a summit virtually in April to talk a little bit about our organizations and where they're going to go in the next few years. And I think that'll allow us to make all of our activities a little more efficient. So if I reached out to you and you're on this call and you haven't filled out the doodle poll yet, I would really appreciate, because I'd like to have that nailed down by that date nailed down by the end of the end of tomorrow if we can. I have a lot of answers, but I think it's an exciting time and possibly an opportunity to get the COT more involved in all of this.
Chris, what organizations are coming to this summit, just out of curiosity?
Well, I reached out to Dennis from the Trauma Commission, the Nita and Renee and Dave, and the I don't have the full Lori, obviously, from the foundation and all those kind of people.
So just Georgia representatives.
Yeah, just for the state. We have so many activities going on now that I think a lot of times we don't, not everybody realizes what everybody else is doing.
Okay, I just want to know if you were talking about state entities or national entities. Sounds like it's just state. That's great. Thank you. I think Courtney had a couple things to mention really quickly.
Yeah. One thing is that, and I don't know that we can take any action on it, but I want you to be aware of it because I live in rural Georgia. In the $900 billion package that was signed back in December, there was a thing in there deep in it that essentially addressed surprise billing for helicopter services. And the way I understand the legislation that was passed and is now law, that starting in January of next year, helicopters will have to negotiate in-network cost or in-network charges for any insurer. I'm not saying that's good, bad, indifferent, but what my perception is that you're going to see some helicopter services go away. That might be right, might be wrong. I'm going to try to get some folks. I've already reached out to the helicopter people, try to figure out what the plan may be. Obviously, the helicopters I think that would be most at risk are the ones that rural Georgia needs the most. Anything like that, when you see volume go down, or you see your money go down, you'll have to get rid of the low volume performers. So I'm very concerned about that. I just want folks to know that is. The other thing is, and I'm going to make it in the form of a motion. I was going to make it as a suggestion to Dr. Ashley, but my motion is something to this effect, that we ask the AG's office to come to our next meeting, and I'd hope that it would be in person, to help us or help me. Y'all may feel better about it than I do, but help us, me, somebody understand our relationship with the Department of Public Health and how we answer to them or not, or how independent we are or not, and exactly what our relationship there is. So I'll make that in the form of a motion. I don't know if Aaron can pick up everything I said and make some sense out of it or not.
I think so. You're asking for the AG office to commit to coming to the May 2021 meeting to help us understand our relationship and how we work independently or codependently with the Department of Public Health.
Yes, you said it much better than I.
I'll second that for discussion.
All right, Courtney, you're going to have to help me here with the rules of order. So is that so now that we have a motion, do we vote on it and then discussion, or discussion and then vote?
No, you'll open it for discussion, and after discussion, then you'll call the question.
Any discussion on that proposal?
Hey, Jim, this is Dennis. I just got back. I didn't hear the motion.
Well, and essentially what I'm asking is that we have the AG's office come to our next meeting and help us understand our relationship to public health and how we function with them, our responses back and forth. And actually made it as a motion because you weren't here. Obviously, if you agree to it, then you can make a phone call and they can just be there.
So then like to come, like they used to come to our meetings and just to come hang out with us and just sort of talk, and we could have a dialect.
Yes, sir.
Dialogue. Okay. And then I'm sorry, I'm coming in on the tail end here. I didn't quite understand. You said our relationship with DPH. Could you just define that a little bit? What exactly does that mean? Well, they're going to ask if they're sitting here, you can just ask them, but they're going to be a little more specific probably.
Well, what I'm trying to figure out is how independent we are or not. I say this a lot. If the state had wanted Department of Public Health to have this money, they could have given it to the Department of Public Health. They elected to set up an attached agency to do the things that we do. And I think we've done a great job. But we've done it a lot of times because we've been independent of some of their processes. So I'm trying to figure out, are we on board? Are we acting appropriately? I think we are, I'll put it that way, but I would like to just ask those questions.
Okay, I understand now. Okay. So I guess there's a motion on the floor, so there's open for other discussion. That was my discussion points. Any other discussion?
Courtney, this is Michelle. I just want to clarify your first statement about the helicopters. So they're going to have to go to the local insurance companies to negotiate those rates versus just charging what they've always charged?
Michelle, that's what I understand.
Okay.
It essentially, there's been a whole bunch of stuff with surprise billing, and that legislation tended to mirror that. I don't know the exact wording of it, but it essentially says if you transport somebody who's not in network, then you'll have to negotiate with the network insurance company to come up with an amount that's appropriate to bill them. This has been a hot topic in my world for a long time. I know there's been some legislators that have ridden in helicopters, got furious about the amount of the charges are. So I'm not for it or against it or defending it or anything. I'm just saying that my perception, and my perception could be wrong. My perception is that when this happens, you're going to see some helicopters go away. And my worry is that it'll be in the areas that I think they're needed most.
Absolutely. Yeah, I agree. Thank you so much for that update.
All right, I'm going to then call for a vote on the motion. So again, we'll vote by just objections, so it's easier to keep up with. Any objections to the motion on the floor? Okay, it looks like that motion carries. So I'll ask Liz to let our AG representative, I'm actually not sure who it is right now, but they used to come to the meetings. I knew them, you know, by face, but there's some turnover there, but we'll find out who that is.
I've got it.
And then have them come to the next meeting, and then it'll be a roundtable discussion. People can ask questions. How's that? Okay. I'm just jumping back in here. Is there any? Are we at the end of the?
We're, yeah.
We're at the end of the.
At the full end of it.
Okay. All right. Well, then, can I get a? Sorry, I had to jump out there, folks. Unavoidable situation. Can I get a motion to adjourn?
So moved.
I second.
Thank you, Dr. Dunn.
Okay. And then again, I'll just take objections. All right, we stand adjourned. Thank you, guys. Good to see you all again, even if it is by just a 2x2 little screen. Your mugs look beautiful. Okay, so.